Well, hi all. I am Michael Morella, Managing Editor of Events at US News and World Report. Thank you so much for joining us for today's webinar, where we're looking at achieving vaccine equity and overcoming vaccine hesitancy in the midst of the ongoing battle against COVID-19. Today's event is part of our ongoing Community Health Leadership Forum virtual event series, where we dig deep into the social determinants of health and how health and community leaders can work together to improve the well-being of their populations. You can find more details about previous programs and upcoming events at usnews.com/events. Now, before we get started, we are recording video of today's webinar, and we'll be making that available on demand for registrants. We're also simulcasting from the US News Facebook page. Now, we welcome audience questions throughout the hour. If you have them, we ask that you please type them into the Q&A feature in Zoom on your screen. Our team will review those and try to give voice to some of them over the course of the hour. Now I am honored to introduce our panelists. With us today are Dr. Sonia Hughes, Vice President of Strategy and Service Excellence at Aetna, a CVS Health business. Dr. Jose Romero, Secretary of the Arkansas Department of Health. Brittany Roy, Program Director for Public Health in the National Governors Association Center for Best Practices. And Julia Ryan, Vice President of Health Initiatives for LISC. Now I'll turn it over to our moderator, Liz Whitehead, with the US News live events team to lead the discussion. Liz?
Thank you, Michael. We're grateful to our panelists for making time available just as the COVID-19 pandemic seems to be reaching a new inflection point. As Michael noted, we do encourage audience members to submit questions, which we'll try to get to as our conversation proceeds. Now, lately, the steady improvements in COVID case numbers over the last half year are being somewhat undone by the spread of the Delta variant infection among the unvaccinated. I'd like to ask Dr. Jose Romero to start us off. Jose, as Arkansas Secretary of Health and as a pediatric infectious disease specialist, can you give us a snapshot of the current situation nationwide and in Arkansas, and how fast is the Delta variant spreading? What groups are being hit the hardest?
Yes, well, thank you very much. It's my pleasure to be here, and thank you for the invitation. So we are, I would characterize it as the epicenter at this point for Delta variant surge in the nation. The South in general is a major site where we're seeing a lot of this. Delta cases due to Delta virus are increasing. Now, we do not have a sampling of all individuals, but I can tell you that from last week, a randomized, a convenient set of samples indicated 72% of all of the variants isolated were due to Delta variant. So it is a predominant strain here, and I would say it's not 100%, but it certainly is making up a lot of it. And by the epidemiology that we're seeing, that is the outbreaks that we're seeing in daycare centers and in places of work, this is probably the cause of it. This has caused a significant increase in the number of cases. Our hospitalizations have increased significantly. As of yesterday, we had 787 individuals hospitalized. Now, while that may not seem like a lot to states like California or Michigan or New York, I mean, that is a substantial number. And keeping in mind that, at our peak, we were about 1,600 individuals hospitalized in January. So we are increasing. We're continuing to see this increase. And we've topped numbers that were high watermarks last year during the pandemic, first phase of the pandemic.
Thank you. So we have a proven tool, the vaccines, to defend against COVID-19 and most of the known variants. But for a range of reasons, people have either had trouble accessing them or they're very reluctant to get them. But tackling the root causes requires first understanding different population groups and what is motivating them or what is preventing them from getting access. I'd like to turn next to Dr. Sonia Hughes. Sonia, CVS Health pharmacies have been dispensing COVID-19 vaccines for months now. Can you talk about the range of communities you're in nationwide, how you've been able to process information at the community level, and how that's impacted your ability to tailor approaches as the pandemic has worn on?
Thanks, Liz, and thank you for inviting me to be a part of this panel and this important discussion. And healthcare is local, just as Jose just mentioned regarding the variant in the local outbreaks being different in different parts of the country. Healthcare is local. The healthiest communities rankings and accompanying analysis serving as a tool to inform residents, inform community health leaders, elected officials about policies and best practices for health outcomes by assessing which communities offer their citizens the greatest opportunity to live healthy, productive lives. And in thinking of that, CVS Health maintains a unique and integral presence in our customers' communities. And we offer convenient healthcare in our stores, and specifically as it relates to the pandemic, we're well positioned to be available to offer the vaccine. Over 85% of Americans live within 10 miles of a CVS pharmacy, and we have almost 10,000 retail locations in our 49 states, including Puerto Rico and DC. So in talking about access, there's certainly the CVS Health saw the importance of using our presence in vulnerable areas and our diverse workforce to support the equitable delivery of vaccine. And I will say, you know, we're proud to even report that 34% of our in-store vaccines have been given to underrepresented minorities. So in thinking about the depth and breadth of the availability of the vaccines, CVS Health is certainly well positioned to address that, and glad to do so.
So Sonia, when you, just to follow up, in the CVS locations, you're both in rural, urban, and suburban areas, correct?
That's correct. You know, 85% of Americans live within 10 miles of a CVS pharmacy. Our pharmacies also have about 1,100 minute clinics across 35 of our states, and not limited to just urban areas. That's correct.
So, Julia, LISC has long been concerned with health equity, and you've taken a really aggressive role to try to bring all that expertise to bear on vaccine access, particularly in Black and Brown communities. Can you talk about what continue to be some of the biggest barriers you're trying to overcome, and how you're doing it?
Certainly, yes. And thank you, Liz and the team, for the opportunity to be with you today. I think what's clear and been discussed quite a bit is that the pandemic had such an outsized, disproportionate impact on Black and Brown communities, and particularly lower income people. And that's true for the health effects of the pandemic, but also the economic fallout. But we're not talking as much about how that all plays into vaccine uptake and access. So I'm grateful for this opportunity that we're focusing on it here today. LISC is hearing from our community-based partners who are in communities all around the country, information that really resonates with some of the more recent research too. The Kaiser Family Foundation just came out with some data that Hispanic Americans and Black Americans are really concerned about things like missing work due to vaccines and the potential side effects. Remember, we're not that far off from the Federal Reserve study that said a $400 unexpected expense could distress 40% of Americans, put them into severe financial distress. So what we're hearing is that communities of color, lower income people have very real concerns about a missed day's work. If you don't have paid sick leave, if you don't have health insurance, and you're concerned about potentially having some healthcare expense arise from your vaccination, those are very real issues that are playing out disproportionately in lower income communities and communities of color. There's also issues of distrust that I think are also very well founded, that have been reported widely, that we need to take into account as we think about how we're going to tackle this and engage a whole range of different kinds of partners to get people comfortable with getting vaccinated and then get them that access they need.
I want to dig deeper in just a bit on the distrust factor. I'm curious whether LISC has had, any of its community groups have been able to collaborate with state and local leaders on figuring out solutions, encouraging local businesses to give. It's often, you know, lower wage workers who are most impacted by this, to give them the time off if they have side effects, to reassure them that they'll get the time off. Have you seen anybody do any trials or any programs to try to get support for these workers?
Yeah, I think there's some new momentum around that, but really the more salient issues of the moment seem to be also just even having the message about vaccines come from a trusted individual, whether that be a faith leader or a community-based organization that can talk people through those concerns. And then we do have partners who are doing some interesting work with employers or just with other kinds of cash incentives to help kind of mitigate that concern about loss of income, loss of wages, help people get more comfortable with thinking about taking that step of starting the process.
Brittany, so in Florida this week, there's a viral story about a 24-year-old young man who contracted COVID. He was concerned about getting the vaccine because he wanted to wait a couple years to see what side effects could be. He was the only one in his family to not get it, and then he got sick. He's had a double lung transplant. He's been in the hospital for 3 months, and they're not sure when he will be strong enough to get out again. He says he wishes he had gotten vaccinated now. From your perch at the National Governors Association, what are you seeing about the state-by-state efforts to try to overcome the fears of side effects, the misinformation all over social media on these vaccines? What can possibly work? Because this seems to be the biggest obstacle right now.
Thanks, Liz. What we've been doing here at the National Governors Association is working closely with governors, their health policy advisors, as well as their secretaries of health to address this very issue. We've taken the approach of nothing for us without us. And what that means is going at the grassroots level. As you guys know, governors have been on the front line of this pandemic since the public health emergency was declared. They understand their constituency base. They understand the need to go at the community and local level to figure out and work through a lot of the issues that we're seeing, in particular, the story you just mentioned about the young man in Florida. We've been doing things such as helping health policy advisors and governors think through what it would look like to utilize family care practitioners. Those coming from a rural area, I can tell you that you trust people that look like you, that talk like you, that have been in similar situations. You're probably less likely to take heed from someone who is removed from your situation. So governors understand that, their staff understand that. We've been working on our end very hard to address a lot of those concerns.
Jose, in Arkansas, the vaccination rates are just over 43% of adults have gotten one shot. Is that correct? And about 35% are fully vaccinated. You may have more up-to-date figures there.
Yeah, our current numbers and looking at the population that's eligible for a vaccine, for example. So, about 41% of our population between the age of 12 and older that are eligible have received vaccinations and are fully immunized. Of the total population, that is those in children, it's lower than that because it includes a group of individuals that can't receive the vaccine. So it's not where it needs to be. We're clearly at the lower end of the scale of states that have been administering and accepting vaccines. But we are making inroads in certain populations. For example, the percent of Latinos, Hispanics that have accepted the vaccine exceeds now the non-Hispanic population. We have a large Marshallese population, and in that population, they exceed all other ethnic minority groups. For African-American population, we're not where we want to be, but we're not, I think, as low as has been seen in other states. We're about 5 points lower than the white population in the state. And we've made specific efforts to reach out to these populations to provide them with the information needed and to reach into their communities in order to deliver the vaccine directly to them.
Yeah, if I could follow up on that. As I understand, ideological resistance may be the toughest nut to crack in some respects in Arkansas. You and Arkansas Governor Asia Hutchinson have begun traveling the state to hold town halls and not necessarily large communities in the past week or two. Can you talk about your experiences, what people have said to you, and whether that has given you, informed your ideas about what you can do to reach out to these people?
Yeah, it certainly has. For me, and it has modified how we're approaching this. So what we're seeing is that there is a substantial portion of the population that has very entrenched beliefs, misconceptions about the vaccine, and to the credit of the governor, he has allowed these constituents a platform to voice their concerns, and then we can answer them. Clearly misinformation that we all have heard. I mean, the idea of the chip and the idea that somebody becomes magnetized by the vaccine. Those are issues being brought before us. Among the minority population, there is distrust. There's concern that the vaccine is safe. But we're making inroads into that as we reach out to them. From my point of view, we thought that we had a very robust, and I still think we do have it, a very robust system of delivering vaccine. We have a centralized healthcare system here, and every county has a local health unit, and at least one, and every local health unit can deliver vaccines. We also work with our federal partners, that is our qualified health centers, pharmacies. And as you know, this is the home of Walmart. And so virtually every county has a Walmart. We work through them. We work through private pharmacies. We work through pharmacies in the Kroger stores. So, we really thought we had reached the population in rural Arkansas. What I learned, is that there are still people in these very small towns, probably hamlets is a better way to talk about them, that don't have access to this or can't get to these sites. So we've now taken another stance. We're now using the Dollar General stores and are working with them to create parking lot vaccinations, because as was told to me by one of my staff, is that you can have a crossroads an intersection of two county roads, and there's a Dollar General there. So we're going to move into that. Our idea of making accessible information, that we were trying to saturate the market with television, with radio, both language specific and Spanish. We thought we were reaching out in there. What we've learned now is that people want paper. They want to be able to go in someplace and take a form home or a piece of paper that gives that information to them. So we're modifying that. And these have been extremely beneficial to us, at least to me, to understand where we need to modify our approach to this population.
So when you're saying paper, are you saying that they want to have information on the vaccine that they can go home with and digest and then make the decision to get vaccinated?
That part of it, yes. And they want they want a sheet that has why the vaccine is safe or why they should receive it. We have those, but we are not getting them out as far into the community as we need to get them. So we're doing that. And we're creating newer ones.
Sonia, can you pick up on some of those points and talk about pharmacists as actually have more touches than family practitioners? Can you talk about what you've done in the pharmacies to provide the information, to have these conversations? And you started to mention earlier about the fact that your pharmacists and your staff in general represent the communities. Can you talk about how these assets have been pulled together to try to encourage people to get vaccinations?
Oh, certainly. And, just reinforcing a comment that Julia made, as well as Dr. Romero, in terms of helping communities, especially communities of color, it's important to work with a network of not only the pharmacists in our locations, but also with community-based leaders, nonprofit organizations, including free and charitable clinics, faith-based organizations, food banks. But you asked specifically about our pharmacists and the touches that they have there. One thing that was important for CVS Health, we conducted a nationwide survey, and what we learned at that time was that the respondents did feel comfortable. A majority of the respondents did feel comfortable receiving a vaccination from the pharmacist. Additionally, clinicians still remain the most trusted source of respondents and of our community. And so with that, CVS Health and Aetna has leveraged its longstanding relationship with the National Medical Association. And the NMA is the oldest organization for African-American physicians. I'm a member. I've been a part of that as a practicing physician and continue that relationship through my position with Aetna. And through that partnership, we're able to support and provide education, not just to the physicians of NMA, but that's certainly one avenue. And to the point that Brittany made earlier, people trust other people who look like them, who can relate to them. So they trust clinicians. And then if you're African-American and you see an NMA physician, an African-American physician, you certainly have a different level of trust. But even more so than the clinicians, the pharmacists, our collaboration and a continued collaboration with other community-based organizations, as I've mentioned, as well as a collaboration with a rideshare service, Lyft, and a universal vaccine access campaign. Our goal is to help those have access, free rides, connect them with vaccination appointments. And then lastly, I'll just mention that we also joined the Ad Council's COVID-19 Vaccine Education Initiative as one of their founding partners for the campaign to educate the public. As Dr. Romero mentioned, I think the public really wants the information in order to build and gain confidence, especially in the Black and Hispanic communities. It's important for them to feel feel the information they're receiving is trusted. So that's been one, those are many of the ways in which we've collaborated with organizations and services to provide this important resource to the community.
Julia, Sonia raised a number of points that I'm hoping that you can pick up on. Ride sharing seems to have been really important. Connecting to community groups that you have longstanding relationships with. I'd like to actually give you a minute or two to talk about how important it is to not suddenly get community relationships started. That if you're going to be effective to deal with not just this crisis, but future crisis, you have to build relationships with effective community organizations all across the country. And can you talk a little bit about how important this is for health equity in general, and talk about some of the specifics of how you've been able to pull different groups, including Uber, I believe, into the pandemic response?
Yes, well, you're so right. Relationships are not built overnight. We often say that we move at the speed of trust in the world of community development. So these are things that are hard won over time as organizations learn to work with each other and as individual people build relationships with each other. And in communities, that also translates where there are organizations that have been hard at work for decades with certain populations or in certain neighborhoods, and they have their finger on the pulse of what is happening, but they also have that trust of the local community. When something like this arises, we need to be empowering those groups to be on the front line. So I really admire the comments of Sonia on that front, and I would underscore what Brittany said as well about trusted messengers of this. For LISC, this has been most apparent in our work with Uber around our vaccine access fund. So in partnership with Uber, along with PayPal and Walgreens, we have resources that we can give to these community organizations to arrange free rideshare Uber transportation to vaccine sites. So
can you explain how that actually works? So if you're working with an organization, I mean, is it a church? I mean, how does the ride get called? How does the individual parishioner or community member, who do they talk to get it set up? Because one of the other issues is some people don't have broadband, they don't have laptops. How does the scheduling get handled?
Yeah, exactly. So we're really focused here on people who might not have a smartphone, might not have a credit card, so that there's barriers to them to using a ride share on their own independently. By working with the community organization, the organizations themselves, in our case, can have access to the Uber Health platform where they can arrange a ride for someone as a third party. And that individual can, get their ride messaging on a phone if they have it, or they can actually get a call from the community organization to inform them about how it's all going to sort out. And it's been critical. We now have 50 organizations around the country that are on board doing this kind of ride arranging for people. And we and Uber and our partners know that transportation isn't the only thing we're solving for here, but it is a tool. and it's just an example, an organization, Mixteca, that we're working with in Brooklyn, New York. They work with Mexican and Latin American immigrants and have for years. And, what haven't they done in the last 18 months to support their community? They've done rent relief, they've done burial assistance, they've done food security work. And now they're talking about vaccines. And what their team told us is, yes, vaccines are readily available all around New York City, but it might be that there's an immigrant family in the Bronx that is only going to feel comfortable coming to our site in Brooklyn or walking with us to that local pharmacy to get that vaccine because they know us and they trust us, and all those other things around health insurance or being asked for ID and immigration status and such will be mitigated by the fact that we're walking arm in arm with them. And that's the kind of tools that we're seeking to activate here in those, hard-won relationships, but also some of these tech tools and frankly, really inspiring corporate engagement in this issue.
That's great, thank you. Brittany, can you talk a bit about some of the mechanisms that the National Governors Association has set up to share best practices between states? And one of the things that's critical right now is you have the sudden spike in COVID cases in some of the southern states. Can you talk about how you work together to get health leaders from similar states with similar demographics together to share the best practices? And what are you seeing now as collaborative efforts to try to address the recent spikes?
Yeah, absolutely. So one thing we know well here is that there's not one policy area that public health does not touch. Our governors recognize that. And because of that, we at NGA have been working tirelessly alongside our governors, their health policy advisors, as well as their secretaries of health to find solutions that are interdisciplinary and customizable. We recognize the importance of what we call putting policy to practice, and that it takes all of us working together, whether that is connecting with industry representatives, private, public, you name it, nonprofit sector. One of the tasks I have here at NGA is working to stand up learning calls or workshops for health policy advisors. I communicate with them daily, if not on a weekly basis, depending on how busy they are. Being a former staffer myself, I know what that feels like. To be trying to do everything right, and somehow it feels like it's not resonating. So when I reach out to the governor's health policy advisors, one, it's to check to see how they're doing, and then two, what resources do they need? What resources do their governors need? I have great relationships, not just myself, but everyone here at NGA in terms of working across the board, whether it be education, kids are getting ready to go back to school. What does that look like? What information can I get from CDC that I can disseminate to health policy advisors who are in the offices with the governors, helping them make very critical decisions. So we have a very open door policy here. No question is too outrageous. We want to know it all so we can share those best practices with our members.
Jose, as Brittany just alluded to, the clock is ticking on the start of the new school year, and a large number of unvaccinated children will be returning to school, and particularly the under 12-year-olds will not have a vaccine yet. We have a number of legislatures have banned forced masking or required masking and vaccinations for kids. What do you do in an environment like that? If you know that you have a variant that's spreading that's more contagious to children, there's likely going to be less masking. What keeps you up at night?
Yeah, that certainly is one of the issues that keeps me up at night, that we are going to see a surge on top of this surge as school begins, because we are one of the states where masks cannot be mandated for school. That went away. We actually last year kept our schools open and did so successfully. And that was in part because we had these physical distancing, barriers for spread, and didn't see large outbreaks. I expect to see this year significant outbreaks within the school system. And what's already telling me that that's going to happen are the number of daycare closures that have occurred because of outbreaks occurring, and the camp exposures and closures that are occurring. So we are seeing that. I think that what I'm trying to do publicly and privately with my own patients is stress the importance of the mask. The misconception that a 4-year-old can't keep a mask on or a 5-year-old can't keep a mask on. They certainly can. They do it in my office. I conduct a complete examination of 45 minutes, and the little ones keep the mask on it, coloring in my room. So, they have to try. We have to stress this. It is the parents that are going to make a difference. If the parents view this as a major issue, they can pressure their school districts, their superintendents to make this something that they want to go forward with. We're considering as an incentive for masking, considering our quarantine recommendations for school, so that this is still in discussion. But if both the individual that is tested positive and the person exposed to that individual are wearing masks, then we may decide that the individual who was exposed does not have to go into quarantine, provided that they are asymptomatic. That may be an incentive for parents to use the mask in school. But that is my concern. And we have one major children's hospital here in the state. We're a centralized system with a small peripheral children's hospital in the Northwest. That hospital already has a significant number of children with COVID in their hospital, and they're being burdened by an upsurge in RSV, respiratory syncytial virus, being seen across the country, in particular in the South. What we're seeing now is that they're full, that they have a limited supply of beds. In 3 weeks, when we start school, this will exacerbate, and that's what I'm very, very concerned about.
I was talking to a elementary school, a county elementary school leader in Texas, and they have a lot of the same challenges that you have. They can't have mask mandates, they can't require vaccinations, and they are trying to figure out the arguments to reach parents who themselves are resistant, because children follow what their parents tell them to do, generally. So one of the arguments that they're using with parents, you don't want an outbreak that closes school again. And if there's one thing that puts the fear of God into parents, is that another year of remote school. So I'm wondering if, in your experience, that resonates at all with parents, the idea that if none of the other arguments work, you don't want a mass outbreak to close schools again.
Yeah, it may resonate. I think that parents, need schools, and I think our governor saw that very early on in the pandemic, that the parents needed these schools so that they could carry on their daily activity, that is to be the breadwinners of the family. And so I think that parents will use that, or you can use that as one of the things to drive this message home about masking, and maybe not as a mandate, but that parents see the benefit of this issue. I think one of the issues that that's being pushed forward is testing in schools, right? That causes a lot of scratching of heads and pulling of our hair out trying to get this done, because the concern is that we've offered this before, and it was not taken up by the school or by the parents or by the administrators. And I think that part of the reason why was that they didn't want to have to close the school if there was a large outbreak. Now, we didn't have that outbreak, but there's a disincentive to testing, and that is you'll find cases and you'll wind up having to close the school. But I think that in the case of the COVID, of this new variant, the Delta variant, it's going to be obvious, that when you have these outbreaks. So
I'd like to talk about a sensitive issue a little bit, which is splits down community about vaccinations. And again, there have been situations where some school districts have set up vaccination sites for adolescents, and we've actually had picketers, other parents, basically yelling at, taunting the parents who are trying to get their shots for their kids. Julia, Sonia, Brittany, feel free to share your insights on that. But Julie, on the community level, to start with you, where are you seeing, are you seeing a problem with hostility to the messenger that you're trying to address through your community groups, and how to sort of lower the temperature so people can talk to each other?
You know, we're not hearing that as much among our partners. I think because they already have those relationships, as we discussed before. In fact, as Dr. Romero was speaking, I just couldn't help but think of a group in Chicago that Liska's long worked with, Southwest Organizing Project. They've been around for 25 years doing range of work around housing and economic opportunity in that community. But they have a network of parent mentors, so paid parents within the school community who have already been developing relationships with families and helping them access a range of kinds of social services or other things in these months of the pandemic. You know, what better network to activate to have a conversation about vaccines, where maybe you could surface real concerns that people have, even feelings of hostility that people have about others around them in this school community. And you can have a dialogue about it, because there's that shared understanding, shared experience, but also kind of the longstanding engagement around we are problem solving together. That's the kind of thing I think we need to pour more resources in at this time, especially as the variant, you know, raises its head and the school year is oncoming.
Sonia, what's your perspective on this?
Sure. You know, I think the point I'd like to make is continuing for those who are vaccinated to continue to speak out and be the example. For instance, you know, our pharmacists have taken the lead, and they're not only giving the vaccines, they're vaccinated themselves. And they're helping to educate the community what a trusted source looks like, because that's going to be the successful strategy for vaccination. So more than 40% of our pharmacists and more than 50% of our pharmacy techs understand the efficacy, and they've taken great strides to get their message out. For instance, we had a pharmacy manager in Wisconsin who vaccinated her grandparents. And this helped to address some hesitancy in a robust community where shamanistic traditions sometimes contradicted traditional medical practices. So that was a bold move. We also had a pharmacist who was active duty with the military. When came back from that assignment, went out into the community and vaccinate the community. We had some pharmacists who actually vaccinated their teenage children. One of our senior executives actually posted on social media when he took his teenage daughter to be vaccinated, to show that he, a physician, trusted the vaccine enough to have his teenage daughter vaccinated. And I think those are the messages that can break down the negative aspects and the negative protests. I think continuing to show that we trust the vaccine, that the strategy behind getting the population vaccinated can help to further the message.
Brittany, do you have insights from your NGA members, just in private conversations, about how they are attempting to bridge the divide from the two sides on the vaccination debate in their states, particularly in the southern states?
Being a Southern myself, I will say this. Again, I cannot stress the importance of peer influencers, community influencers, people that resonate with the folks that you're trying to reach, and having safe spaces. I'll just share a story about me. When, you know, word came out that, you know, the vaccine was available under the EUA, and, you know, we go through all these allocation phases, I was nervous at the beginning and was hesitant. But I will say that I have a group of folks around me that are way smarter than I am, and allowed me to ask questions and answered them thoroughly, and didn't make me feel like, you know, I had egg on my face. And that persuaded me to get the vaccine. I think a lot of what we're seeing is not unreasonable, especially when you're talking about, you know, studying the behavior, the underlying conditions of why folks are hesitant. And I cannot stress enough the work we're doing on this end to address those concerns, whether it's working with behavioral scientists to get to those root causes, whether it's folks in the Bible Belt of America who have religious reasons for why they don't want to move forward. I think those are all realistic concerns that they have.
So, Jose, you mentioned that you'd had some better luck with Black and brown populations, and that there were certain groups that you had been able to tap. Can you talk about some of the groups that you were able to and then the Marshallese population? What specifically worked?
Yeah, so in the Marshallese population, it was their thought leaders and their physicians that were really instrumental in bringing actually the pandemic under control in their community because of their extended family nature of the community, and they've done wonderful in taking possession of this and taking ownership of the issue and moving forward. So I think that's part of it, is working with those thought leaders, the physicians in their group, convincing them that it's important, and they have tremendous sway among the population. And with regard to our African American group, our minority outreach here has relied on sororities and fraternities, African American sororities and fraternities, to set these events up, and they do it with tremendous gusto. I mean, they're reaching out to their communities. We have reached out to Black churches using our church-based liaison here and work with them. Our policy is here that you call us on a Wednesday if you're having an event on a Sunday, and we'll get there. There is no delay in getting this set up and getting it out there. Our group is very, very keen on that. With regard to the Latino population, I'm very lucky that a number of my staff are bilingual. I have a weekly interview with a television station, and we chat about what the issue of the day is, and I think that has helped get that message out. So we're using every avenue we can to try to reach into these communities. We still have a lot of work to do. I mean, there's no question about it, but we are moving into those communities.
Sonia, you talked a little bit about some of your partnerships. Can I ask you to talk a little bit more specifically about? I know that CVS Health does a lot of services outside of its bricks and mortar settings. Can you talk about how you activated those during the pandemic?
Certainly. As I mentioned previously, and to just reiterate and support the points that were made, leveraging information that we received from respondents on a national survey to understand the various communities and how their views on receiving the vaccine. And so given that information, able to have a community tailored approach. As I mentioned, and I think one of my earlier comments, healthcare is local. So, if we were going to improve the health of our community, we must first understand the population's health and understand the traditional beliefs, and to the point that Brittany was alluding to, why certain populations don't trust the healthcare system. And then given that information, can then tailor those partnerships. And Dr. Romero, I'll say I'm a member of one of those sororities. And yes, we do things very robustly. We make sure we assert ourselves into the communities. And that was a great approach. And kudos to the state of Arkansas. And then similarly, to answer your question, Liz, the relationships that CVS Health has had, basically looking at the information, leveraging our longstanding relationships. Julia alluded to it earlier. You can't just insert yourself into the community now, as that trust has to be established over time. We've had a relationship with the National Medical Association. We've had a relationship with organizations like the YMCA and other charitable and free clinics, faith-based organization and food banks, because the CVS Health and Aetna foundations have long supported the various communities. And then lastly, we certainly, as I mentioned, joined the Ad Council's vaccine education initiative and leverage that relationship to tailor community-specific initiatives to address the hesitancies in those various communities.
Thank you. We have an audience question on a point that we haven't touched as much on, which is outreach to migrant and rural communities. Julia, Jose, could you talk about, because that is, it's a big population, and what are some of the programs that are out there right now to try to reach those groups which may have the least access to vaccines?
Sure. Well, I can offer that we've had a lot of interest from various immigrant and even migrant worker groups around the country for the Vaccine Access Fund around transportation issues. I think, again, they're just seeing that the issues around vaccine uptake are indicative of other struggles or challenges that their constituents, those communities, have faced. It relates to distrust, concerns about lack of health insurance, concerns about employment stability, just overall family stability, and the underlying health issues that tend to be more prevalent in those populations as well. And so they've already been in the thick of all of those things, and now they're trying to layer on access to the vaccine, building common information and comfort with it, but also access through transportation and other tools that people need to really to get to a point where they're willing to start the process, and they can. Community Health Worker Coalition of Migrants and Refugees out in Washington State is one that's just been most informative to us as they start to roll onto our program and try to start using rides to bring people in the door.
That's great. Jose?
Yeah, so this issue really begins also with information directed to the individuals. And so, organizations like the United Farm Workers, have had webinars to their constituents, and in Spanish. I've given them in an attempt to reach into the community and inform them why they need to believe that this is a significant illness and to get the vaccine. We also, within the health department here, we will deliver vaccine to these individuals. If there is a migrant community or migrant group of individuals that needs it, we will go to that site and administer the vaccine. We have to be able to deliver the vaccine to them. And we're a smaller state, but at least our commitment has been, no matter where the employer needs us, we will go and set up a vaccination site at that center. And going back to that, I mean, in phase 2 of our vaccine rollout across the country, we targeted specific industries, the meat packing industry, for example, or there was poor uptake in certain areas. We are going back to those areas, to those manufacturing or businesses, and offering again the vaccine. And it's the same with our teachers. Our teachers had very poor uptake in vaccine. I'm sad to say that it's less than 50% across the state. And so now we're going back and trying to set up again directly at the schools themselves sites for the teachers to go ahead and be vaccinated like we did the first time. So we're going to have to go back. We have to take us another step backward in order to give them another opportunity.
Thank you. So Brittany, we have an audience question for you in the NGA. Asking about tools that public health leaders can access through the NGA to work together with their peers and other policy teams to address vaccine hesitancy.
Could you clarify that question a little more?
So public health leaders in our audience are asking, are there tools that they can access through NGA where they can come together with other public health leaders to get their ideas and develop policy ideas or program ideas they can take back to their communities?
Yes, so I would say check out our website. Everything we do that we think is important to share with the masses is there. We work closely with the CDC as well as HRSA and our sister organizations such as ASTO and NACCHO, et cetera, on these very issues. So our website, nga.org, would be the quickest way to gather that information. And then my email address, as well as some program directors in different policy areas here at NGA, is also listed on the website. So I encourage you to reach out. I am here to help.
Thanks. As we get to our closing minutes, I'd like you all to take a moment and talk about what the ROI is of inaction versus the return on investment of action right now, that we have putting in, how important it is to put money into the resources we need to get people vaccinated in terms of lost work, whether to the individual, what happens if you get sick, what happens to communities if there are big outbreaks. I'd like to give you a chance to all address that. Dr. Romero, do you want to start?
Sure. The low hanging fruit is that, this epidemic, this pandemic will continue until we have enough individuals vaccinated. And the impact economically, the impact on our healthcare systems will continue to go forward. We are seeing now in our state, we're staring down the barrel of, shortage of beds, not so much because we don't have the bed capacity, but because we don't have the staff to staff that bed. And so if this surge goes forward, we're going to have problems where we can't provide care to somebody that has an automobile accident because there are no intensive care beds to be staffed appropriately. So we need to look at that. In the long run, we know that that infection with COVID leads to what is now called long COVID, or longer symptoms. 10 to 15% of the population will have that. Think about what the economic burden is on the state, on the healthcare system in going forward. The burden of this disease in children, right? Our children have already suffered 1 year of an altered educational system, right? We may be getting ready to suffer a second year. So now we have 2 years in which our children have not received education at the level we need in order to move forward in this country. In the long run, this may be the most devastating pandemic that has hit, modern society, even far greater than the influenza, great influenza, because although it had significant numbers of deaths, the economic, the long-term implications of this for our children, and for those going forward will be significant in years and decades to come.
Yeah, Sonia, do you want to pick up on that?
Sure. I definitely cannot add to anything that Dr. Romero said. I basically can just say exactly right. One thing that I think is important for us to note at this point is something that we've learned also is that during this pandemic, not just our physical health was affected, but also mental health and mental well-being. And one way that CVS Health has addressed this is we started an innovative program called Here for You, a peer support group. And it's for people who are our customers or not our customers. And we began providing depression screenings in our stores and clinics and began staffing our health hubs with licensed clinical social workers. So I think in addition to everything that Dr. Romero just mentioned as long-term effects on education and on health, we need to also remember the mental health and address the mental well-being.
Julia, LISC is so conscious of the importance of investing in health equity because of the long-term cost if you have chronic illnesses develop. And as Dr. Romero just pointed out, you long haul COVID, which is affecting a very significant population, even the younger kids, I think they're talking about up to 5% or more, maybe. Yeah. So Julia, can you talk about just give your perspective on this idea of communicating why this is well spent money to invest in effective health equity efforts in terms of either vaccinations now or in related health crises in these communities?
Yeah, I think we have to consider that even before the pandemic, we had a gap in wealth between the average Black family and the average white family that was more than 10 times. We had gaps in life expectancy between Black and brown neighborhoods and more affluent white neighborhoods that are in some cases 10, 20, 30 years. And we're talking about neighborhoods that are blocks apart. This is all because of structural health inequities that have been around for decades. And then you layer the pandemic on top of that and low vaccination rates along racial and ethnic lines on top of that. And we're just amplifying these problems that affect the prosperity of the country overall. It took 2020, a year of a pandemic, an economic recession, and a racial reckoning for us to realize that we are all in this together. We have to resolve all of these issues together to get to be a truly equitable and prosperous nation. So I'm looking at this as the long haul. What's the ROI, not just for vaccinations in the near term for those families, which I think is very apparent, but for not investing in digital equity, for not investing in affordable housing and quality living conditions for all of us. I think it's really apparent now, the impact of that on what will happen in the next pandemic, or just what will happen in the country in the years ahead?
And the final question, do we feel that by next fall, there's reason to be hope that we will be really coming out of this pandemic? Or is it really going to be dependent on how we deal with this latest upsurge? Dr. Romero?
By next fall being the fall that's coming.
A year, 12 months from now.
Oh, 12 months from now. I think that I think we will be coming out of this at that point. If we continue with this this variant, I think we're going to wind up with a natural, if you will, and I hate the word herd immunity, but enough people infected that it will begin to decrease. Now, the bigger problem is this: it's not just us; it's the rest of the world. And because we have an example of that, the Delta variant was identified in India because of the large number of individuals that could be infected and the ability to propagate this virus in that environment. There are areas of the world that are in a similar situation that have no vaccine. And as long as those areas exist, there is the possibility of development of new variants, variants that have a different phenotype, a different characteristic than the current variant, and may overwhelm our own systems for immunity at this time. So this may continue into the future. We not only have to worry about ourselves, we need to worry about the global impact of this virus, and we need vaccine. And I'm sorry I took so long on that answer.
No, it was great. I mean, we're going to have to stay vigilant, and we're going to have to stay on top of it. It seems to me that there's going to be not just this pandemic, but future ones. And I think the hope for all of us is that we're learning critical lessons about how we need to respond to them and how we need to mobilize our resources. I'd like to thank our terrific panel, Dr. Sonia Hughes, Dr. Jose Romero, Brittany Roy, and Julia Ryan for sharing their insights and demonstrating again how dedicated public servants in health and government, community organizations, and major corporations are continuing their extraordinary efforts to get us beyond this pandemic. Thank you so much, all of you.
Thank you.